choice होता है PET scan. All the cancers, investigation of choice to see the distant metastasis would be a PET scan, right? Okay. अब let us talk about the esophagus. Suppose करो बेटा ये esophageal cancer. There is a patient of esophageal cancer. Suppose patient has come to you with dysphagia. So for dysphagia, first we do a barium swallow, and there in cancers we can find a filling defect and a rectal appearance. That will give us an idea that this can be a cancer. To prove this as a cancer, we do upper GI endoscopy and take a biopsy. So first investigation is barium swallow, but investigation of choice would be upper GI endoscopy and biopsy. Biopsy में cancer. Now to stage, we do a CECT, and for metastasis, PET scan. If suppose there is a patient who comes to you with epigastric mass, stomach cancer की बात करते हैं. Now any patient presenting with a mass in the abdomen or swelling in the abdomen, the first investigation will always be ultrasound. And if you find a mass inside the stomach on ultrasound, then you do upper GI endoscopy and take a biopsy from the mass. And then if it turns out to be cancer, for local staging you do CECT, and for metastasis again a PET scan, right? If suppose the patient comes to you with melena, so first thing what we have to do is we have to see the patient is selling black tarry stools, but whether there are blood cells in the stool or not. So first we have to do stool examination for occult blood, and if occult blood is positive in the stool, then we start feeling कि boss ये तो black colored stool है जिसमें blood है. That means there is bleeding in the upper GI tract. So it is patient is coming with melena. Okay, if blood is positive, don't do a lower GI, do a upper GI endoscopy. Right? If it is a lower GI malignancy, it will present as bleeding per rectum. But if it is the upper GI malignancy, stomach duodenal malignancy, that can present as melena. So if melena is there and stool for occult blood is positive, bleeding from the upper GI tract, so do a upper GI endoscopy. And if you see a tumor inside the stomach, take a biopsy. If it is cancer, CECT for local staging. And for metastasis, PET scan. Same way, beta. If you talk about the colon cancer, right, presenting with bleeding per rectum, do a colonoscopy, whole colonoscopy, complete colon is visualized. If you see a tumor, take a biopsy. Staging, CECT. Metastasis, PET scan. Now, if suppose we are talking about a rectal cancer, so beta rectum is there in the pelvic area. ध्यान रखना बेटा. Patient presenting with bleeding per rectum. Do a colonoscopy. You find a tumor, take a biopsy, and then for staging, local staging in the pelvic area बेटा. अभी अपने याद किया था ना? We learned it that all this area MRI, this area CECT, but pelvic area MRI. So rectal cancer, staging investigation MRI, and distant metastasis same PET scan. Okay. Suppose the patient comes to you with anal canal cancer, then the mass coming out of the anal canal. You can take a direct biopsy, just like the oral cancer. You took a biopsy. Same way, anal cancer, you can take a biopsy, and then for staging purpose, you do a MRI, and for distant metastasis, you do a PET scan. Right? Patient of gallbladder cancer or pancreatic cancer, if the patient comes with jaundice, first investigation in any jaundice patient will be LFT, then ultrasound. Okay. Now, if suppose ultrasound shows a mass inside the gallbladder, you cannot take any endoscope inside the gallbladder. So it will be difficult to take a biopsy. If suppose you want to take a percutaneous biopsy under ultrasound CT guidance, suppose you feel that there is a mass inside the gallbladder, let me put a needle and take the biopsy from the gallbladder mass. When you are taking out the needle, there is a risk that you might spill the cancer cells in the peritoneal cavity. If you spill the cancer cells in the peritoneal cavity, you will disseminate the gallbladder cancer in the entire peritoneal cavity. Before your effort, before you put the needle, cancer was inside the gallbladder. Patient would have been successfully treated by removing the gallbladder and maybe some surrounding area. But if you have taken a percutaneous biopsy and you spilled the cancer in the peritoneal cavity, now if you have to cure this patient, you will have to remove the entire cancer from the patient. That means you might end up in removing the entire abdomen, abdominectomy. All the abdomen is gone, followed by a thoracopelvic anastomosis. Is this possible? No. That is why we say all those areas in the body where there is a risk of spilling the cancer cells and taking the biopsy, we don't take biopsy. That means any cancer which is outside, oral cancer, anal cancer, penile cancer, direct biopsy. Any cancer where biopsy can be taken by endoscope, upper GI endoscopy, lower GI endoscopy, urethrocystoscopy, ureteroscopy. Endoscopy and biopsy is the investigation of choice. But like the outer part of the kidney, you cannot pass any endoscope in the outer part of the kidney. So endoscopic biopsy is not possible. Similarly, in the GI tract, esophagus cancer, stomach cancer, rectal cancer, colon cancer, upper GI endoscopy and a lower GI endoscopy, that is colonoscopy, you can take the biopsy. But if you're talking about gallbladder, where endoscope will not go, percutaneous biopsy is contraindicated, don't do it. Better to just do a CECT, and based on CECT findings, you decide that yes, now you have to plan treatment according to the cancer. Okay? Fine. So let's move further. We were talking about the gallbladder malignancies. So here we can do a CECT and then plan our treatment and PET scan for metastasis. Okay, the same story would be for pancreatic cancer with a slight difference, which we'll see when we'll be talking about pancreatic cancer. Then kidney cancer, again, we cannot take a biopsy, so CECT. Bladder cancer, painless hematuria, first urine examination for malignant cells, urine cytology for malignant cells. Kidney cancer, if it presents with painless hematuria, patient comes to you and says there is blood in urine. So you evaluate the urine first and look for cancer cells. If cancer cells are present, then you start suspecting bladder and kidney cancer. More common is a bladder cancer. So if urine cytology is positive for cancer cells, first investigation to be done, cystoscopy. And if on cystoscopy you see a tumor inside the bladder, take a biopsy. So cystoscopy biopsy becomes investigation of choice for bladder cancer. But suppose patient comes with painless hematuria and urine cytology is positive for cancer cells, you do a cystoscopy and you don't find any tumor in the bladder. You start thinking that this can be a case of kidney cancer.